Now I am going to introduce a wonderful doctor. He told me I could just say, hey, it's Dr. Joe. So, hey everybody, it's Dr. Joe. Here he is. And I'm going to give him a little introduction. He's the director of the Neuro-Oncology New Jersey Neuroscience Institute Brain Tumor Center here at JFK Medical Center.
Thank you.
You're welcome.
Hi, everybody. So I was asked to talk a little bit about adult gliomas. And so I'm going to also include grade 2 gliomas because we often forget to bring them about in a lot of our lectures. And so I wanted to touch a little bit about that. And then I was asked just to talk about some of the trials that are available here at JFK. So gliomas are divided into 4 types. You know, there's 1, 2, 3, and 4. Those are the grades. We don't have stages like they do for other cancers like breast cancer, colon. It's just a grade. And the grade 1 is really limited for children who have the most slow-growing or indolent type of brain tumor. The grade 2 is the low-grade astrocytoma, well-differentiated. Grade 3 and 4 we're very familiar with, the anaplastic astro and the glioblastoma, and those are the ones that we typically utilize radiotherapy and chemo for. So just to talk about the low-grade astrocytoma, they're typically non-enhancing tumors of the brain. Lots of patients I see that have non-enhancing abnormalities that may or may not be brain tumors that we're simply following with scans because they may be in a dangerous location to find out definitively through biopsy. I'll show you an example. Typically, it depends on the age, and there's a lot of controversy with low-grade astrocytomas. Historically, for children, they were always removed, and that's still the case. For adults, historically, they used to just be observed. We never used to resect them. So they took a group of patients, 100 here, 100 there, and they observed half, and then they treated the other ones with surgery and other therapies, and there was no difference in the overall outcome between the 2 groups. So people said, so why not just wait? The problem with that is that the tumors can cause neurological problems. And so more of the recent data, and you're still going to see 2 fields of thought, is really advocating for early treatment. So for my adult patients that have a low-grade or presumed low-grade tumor, glioma, in an area that's resectable, I recommend resection. I certainly recommend resection over the age of 40 because sometimes you can be fooled by the scan where the tumor may be more aggressive than the scan is letting you believe it is. So we can make a diagnosis through biopsy if it can't be removed or through resection. This is my practice parameter, and this is probably the practice parameter of probably 70% of the neuro-oncologists in the country. Neuro-oncologists and neurosurgeons also differ a little bit in how they approach the low-grade glioma. For patients who are over the age of 40, I recommend radiotherapy after resection because for over the age of 40, they can become a higher-grade tumor sooner than when they're under the age of 40. Certainly if there's a high growth rate. So if it looks like a low grade, the biopsy says it's a low grade, but the growth rate, the mitotic rate that we look at is a little high, higher than 5, 6, 7, then I'm going to recommend radiotherapy as well. And certainly for patients with progression or recurrence, some studies at Sloan were trained. We did use radiotherapy for patients with refractory seizure, and it can improve seizure control. Under the age of 40, I typically wait unless there's a high mitotic rate or other concern. Chemotherapy is typically used at recurrence historically, but some people choose to use it up front with the radiotherapy, chemotherapy followed by radiotherapy. And then certainly the most important thing is follow-up imaging. We want to continue to monitor the disease so that we can address changes that occur as they come. So I'm pretty loud, Patty. So as Dr. Vogelbaum talked, in the next slide, I think, the next couple slides are going to talk about, there are chromosome deletions that are typical for oligodendrogliomas. But we're now using those deletion studies for astrocytomas as well. And there are a couple of other markers that may give us prognostic significance, things called IDH1 and 2 that can be used for prognosticators for low-grade astrocytomas. The 1p19q, the large studies are being done, and once we know the results of those, will tell us if we're doing the right thing in the way that we guide our therapy. So I already use those chromosomal deletions to guide the therapy that I give, and these large trials that are getting done will tell us if we've been right. So this is a typical appearance of a low-grade glioma. There on the left side of the screen in the front. It doesn't enhance. It's just sort of diffuse and infiltrating. Oligodendrogliomas also are low-grade or high-grade, grade 2 or grade 3. Treated the same way, surgical resection. A little different for the anaplastic oligos is the chromosomal deletions. Like I said, we are using them for the low-grade astros and oligos, but the chromosomal deletion studies were first identified for the anaplastics, seen in about 2/3, and it helps guide our therapy. So if I have a patient who has an anaplastic oligodendroglioma and the deletions are present, meaning the 1p19q deletions are present, I'm going to treat them with Timidar. And I'm going to give them the Timidar for up to 2 years. If they progress in that first year, I'm going to flip them and I'm going to treat them with the Stoop protocol, radiation and Timidar together. If the deletions are not present, I'm going to treat them with radiation and Timidar right up front. And that's pretty much how most people do it, again, probably 70–80% of us. But the large trials that Dr. Vogelbaum talked about that the RTOG did will tell us if we're making the right decision. Historically, PCV was used. We tend not to use that anymore. Some people do. It's 3 drugs versus 1. I like the Timidar. It's well tolerated, and you get the same response rate. Certainly, radiotherapy at recurrence. You guys can feel free to interrupt me like at any time. If you have questions on particular slides, I'm not very regimented. Unless you're my patient, right? You have to be on time.
Oh, and we all have to be on time?
You got it, Sue. You have to be early.
I said something about 1p19q.
Yeah.
Deletion. When I sent tissue out, they said that wasn't present, and I had the anaplastic astrocytoma, we think. Now, what significance does that have?
Just because I know you, it's not going to have much significance. Yeah, it's no significance. I mean, I don't want to violate HIPAA, but I know your pathology, and it's not going to make a difference.
Okay. I just wondered in terms of long term.
Yeah, the 1p19q doesn't apply to you whatsoever. This is more of what an anaplastic tumor looks like, enhancing on a T1 with contrast film. Not really a lot of necrosis here like we see with glioblastoma. So anaplastic astrocytomas have been treated different ways by different people. MD Anderson, I'm sorry, did I miss somebody? Really? No, go ahead.
You had an anaplastic oligodendroglioma. So does that mean if P19 is present, this extension of life could be longer?
So historically, yes. In the studies, when 1p and 19q deletions are present, that confers a better response to therapy and typically a better prognosis. But we're still learning. You know, we're still learning. But right up till now, that answer is yes. So the other thing that we look at are MGMT, which we'll talk about if you want. So the anaplastic astrocytomas tend to occur about a decade less than the glioblastoma, but they're typically treated the same way. We use the Stoop protocol, radiation, and Timidar after surgery. Some places still choose to use PCV. As everybody knows, the FDA has only approved the anaplastic, the Timidar for recurrent anaplastic astrocytomas, but we use it up front as initial therapy. And unfortunately, more recently, my nurse Patty and I have been having more and more difficulty getting it approved from the insurance companies. Every tumor has a code. So a malignant brain tumor has a particular code. So I used to just give the code and get away with giving people who didn't have the drug, a tumor that was approved by the FDA for the drug because I felt they needed to have it. Now the insurance companies are asking for histological diagnoses. And so it's getting more and more difficult. There's ways around it. But it's getting hard. It's getting hard. It keeps me up. It's stressing me out. Glioblastoma is the grade 4. Okay, typically at this point we see necrosis. It is one of the most difficult to treat. Most common, about a decade older, 5th and 6th decade of life, and certainly is an enhancing tumor. This is an example of a glioblastoma, and you can see that the center sort of looks a little blackish, and that's the necrotic center where the tumor sort of outgrows its blood supply. So we're going to talk about the treatments for the grade 3 and 4, and we briefly touched upon the low grade. There's about 24,000 malignant brain tumor patients each year in the U.S. at present, based on the most recent data. Typically, the treatment is surgery. We try to go for a gross total resection. So what does that mean when your surgeon tells you gross total resection? Dr. Vogelbaum showed you an enhancing scan, but then there was this non-enhancing abnormality around it. When we talk about gross total resection, we're talking about removing what enhances. And that means more than 98% or less than 1 cubic centimeter of disease left, okay? That's what they mean by a gross total resection. Anything less than that is not a gross total resection. And the reason that we want that is because historically, based on all the data, that gives us a better prognosis. Then we treat with the Stoop protocol, chemoradiotherapy with Timidar. We're going to touch upon each of these avenues. Avastin, everybody knows, for FDA approved for recurrent glioblastoma. We're going to talk about that, and we'll just touch upon using it up front, meaning with a newly diagnosed glioblastoma. And then I'll talk to you about the clinical trials that we have here, some of which Dr. Vogelbaum talked about as well. So for a patient who undergoes resection for a glioblastoma, some of the slides are busy and probably a little complicated. Ignore them. Just listen to me. I'll just tell you. It's easy. It takes me 5 hours to read one slide to figure them out, and then I'm able to communicate pretty clearly. So glioblastoma, all right, if we do more than a 98% resection, there's a better survival. And that's why we go for as much that we can remove. Your surgeon may or may not, this is the only graphic slide, choose to put in Gliadel wafers. Gliadel wafers are small chemotherapy-embedded wafers. They have BCNU in it, the drug that we've been using for 30 years for these tumors. First drug FDA approved for the treatment of glioblastoma in the surgical cavity. They typically put 8, they push them on the sides of the wall after the resection, and there are several papers now showing improved prognosis when these wafers are placed. About 2 months. So LaRocca did a lot of work. There's several large studies that were done showing a survival benefit, with the theory being that it acts as a bridge from the surgery for the time that you're waiting to get the chemotherapy and the radiation. Typically, we like to start radiation and chemo within a couple of weeks of surgery. When Gliadel's placed, we need to wait 4 weeks. Radiotherapy basically has been the cornerstone of treatment after surgery. Up until Timidar, no matter what chemotherapy that we added to the radiation therapy, we did not see an improvement in survival. Timidar was the first drug when it was moved with radiation. The Stoop protocol showed a statistically significant improvement in survival. I wanted to just put one slide up for radiosurgery. I'm the director of the Gamma Knife across the street. I'm one of 2 neuro-oncologists in the country that perform radiosurgery. And I will tell you that I get asked the question a lot, is my tumor eligible for CyberKnife? Is it eligible for Gamma Knife? The RTOG did a large trial. There's no benefit whatsoever to treating a glioblastoma, a grade 3 or grade 4 for that matter, even a grade 2, with radiosurgery, at least up front. If somebody has recurrent disease, small areas of nodular recurrence, and I mean like a centimeter and a half, so like the size of a dime, size of a nickel, that's appropriate for radiosurgery when it comes back, but we also switch chemotherapy. And it's not that hard to understand. The radiosurgery focuses the radiation to a small point. And we could treat as much of an area as we want, but the larger area we treat, the lower the dose is, because you can't risk the normal brain, so the less effect you have, okay, on the tumor. It doesn't make sense to treat an invasive tumor with something that just gives a local dose of radiation, okay? And so for that reason, it really hasn't been effective. Chemoradiotherapy, everybody's familiar with. So Timidar is indicated for the treatments with newly diagnosed glioblastoma with radiation, and then it is post-radiation. The protocol, the Stoop protocol, was 6 months. I like to give it out 12 months. Some people do 9, some people do 18. 12 months, at least there was some data to show 12 was better than 6. They did a phase 2 randomized trial, okay, and it basically they found a statistically significant improvement in survival, and we'll talk about that. Patients should be prophylaxed against PCP pneumonia. If everybody's familiar with AIDS, PCP is a type of pneumonia that immunosuppressed patients get. Bactrim is 100% prophylaxis against the PCP pneumonia, so if you're allergic to sulfa, there are other medications that can be used. I've had several patients that I've seen midway through their course that were never given the prophylaxis, and that's not something that we want to practice. They should be prophylaxed. So this is the curve. The curve on the top is radiation and Timidar together. The curve on the bottom is radiation alone, because then we used to give the Timidar afterwards. And what we see here is that the survival curve is better for those that receive the radiation and the Timidar, with an average survival, and I purposely deleted survival out of almost all my slides, but we're going to just talk about here, of 14.6 months on average. I have people I'm following for 9-10 years now, so, and they were treated with BCNU even before the Stoop protocol came around. The 5-year analysis for the Stoop protocol showed a 10-year survival at 10%. And the reason I put these up here is because when I talk about the clinical trials, we're going to talk about the phase 1 trials and what the survival data looks like and why these trials are exciting. The most important care, in my opinion, for any brain tumor patient, whether it's a meningioma, brainstem glioma, acoustic neuroma, benign, aggressive, non-aggressive, is MRI scans. Too often, I have had patients who, most of the time meningiomas, a couple of times gliomas, where their surgeon said, it's out, you don't have to worry anymore. And then 5 years later, they come back and the tumor is very large. So follow-up imaging is very important, and depending on how aggressive the tumor is, tells us how often we should do it. For my malignant brain tumors, I do them every 2 months for a year. As long as they're getting chemo, then every 3 months. I never go beyond every 6 months. There are a handful of patients that I take care of who have had low-grade oligodendrogliomas who are out 10 years that I might start following yearly. But I'm very, very, a year's a long time. I mean, a year is a long time. A lot can happen in a year. So not even with a tumor, just in somebody's life, a lot can happen in a year. And I like to know my patients fairly well, so I like to check in every 6 months. But I think it's important to check their tumors that way as well. Pseudo-progression. Is everybody familiar with pseudo-progression now? Only because it's so difficult sometimes to explain that I thought I would throw it up there because it is something that's important. Patients who are treated with radiation and Timidar together, typically we do the first scan 4 weeks after that completes before you start your monthly Timidar. That first scan can look like the tumor has come back, meaning there's more enhancement, it looks ugly, it looks aggressive. We don't know if that's the case. There's something called pseudo-progression. 50% of the time when we see new enhancement on a scan in somebody who received chemotherapy and radiation, it's pseudo-progression. So we have new criteria now. It's called the RANO criteria. So there are new ways that all of your doctors and your family's doctors should be looking at the MRI scan. You cannot call progressive disease within the first 12 weeks of chemo and radiation, okay, unless the enhancement is outside where the radiation was given, or you go and get a tissue diagnosis. So your doctors, I've had patients who have come to me from other centers where they had progression on the scan, their chemo was stopped, and then they didn't do anything. And they came for a second opinion, and I said, well, let's see what it looks like now. So the rule is, if you see that progression, you should repeat the scan in a month, continue the chemo, continue the Timidar, and if it's better, it's pseudo-progression, because you haven't changed anything. And if it looks worse, then you need to make a decision. Do you want to wait another 4 weeks, or do you want to switch the therapy at this time? So a lot of the times when Avastin was first used for recurrence, a lot of the time they were probably treating pseudo-progression. They progressed on the standard of care, got Avastin, and it all disappeared. It's probably because it was within that first 4 to 12 weeks. Avastin. So Avastin is now FDA approved as a monotherapy, meaning by itself for recurrent glioblastoma. There's a drug called irinotecan or CPT-11 that was done in some of the original trials, both at Duke and out in Texas. It really added very little as far as the efficacy goes with regards to controlling the tumor, but did add significant side effects. The 6-month progression-free survival on Avastin is 42.6%, which is very good. So not only do you get a response, not only does it help enhancement, tumor shrinkage, edema, but it's durable. It lasts. There's a small study done for my colleagues at Sloan Kettering where patients with recurrent glioblastoma received another 5 days of radiation along with Avastin. And the purpose of that was to show that it was safe to do. It did show that it was safe to do, and they had some pretty good results. It's not my standard practice. I don't re-irradiate my glioblastoma patients, at least not at first recurrence, but would consider it later down the line. Only because there's not enough data there. It was 25 patients. That's not a large enough number to really draw any conclusions, and there are downsides to re-irradiating somebody. Avastin up front. So to date, there's been 2 or 3 trials that were done, one of them out in LA, where they used Avastin along with the Stoop protocol, radiation and chemotherapy after surgery. And what they found was that the time period before the tumor grew back was longer. So there was a longer progression-free survival by a few months, but no difference in overall survival. So there's a trial that just finished, that just closed, or analyzing the data, called Avaglio. And Avaglio is going to tell us whether or not we should be using Avastin up front. Most people don't use Avastin up front. There are a handful, 10, 15, 20% of neuro-oncologists in the country that do use it up front. Just to go through a couple of questions.
Yeah, I've heard some anecdotal evidence that Avastin initially makes the tumor shrink, but somehow it generates activity and the tumors come out other parts of the brain.
Yeah. So there is something called, the way that normally these tumors spread, okay? The tumors secrete a chemical. The chemical breaks down the jello mold of the brain. And what that does is it releases other chemicals that cause blood vessels to form, and the tumor spreads. That's how the tumors invade. The Avastin cuts off the formation of those blood supplies. And so in the earlier studies, this is probably going back 3 or 4 years ago, and some of the studies that were done 3 or 4 years ago, there was this question, well, did the tumor learn a new way to grow? And so there are little spaces other than blood vessels in the brain that we have. And the theory was we cut off this mechanism, and now the tumor's invading in a different mechanism. And so what you get is non-enhancing tumor that's diffusely infiltrative. And I will tell you that I've seen that. There's several very good papers now published in the last 2 years, and we did our own analysis across the street, that the pattern of growth does not change from Avastin. So it was out there, it was talked about, but the larger studies that were done, because it was anecdotal, showed that the phenotype, the way that we present ourselves, or the way the tumor presents itself, does not change as a result of Avastin, although that was a concern. So just a couple of general questions. Steroids. Steroids are very good when you have to reduce swelling. Steroids are very good to make somebody overcome a neurological deficit in preparation for surgery or for radiation. I like to get my patients off of steroids as soon as possible because steroids are a terrible thing, right? They're good and they're bad. So they can cause diabetes, they can cause psychosis, but the big thing that they do is they cause, one, weight gain, and steroid myopathy, where you get weak in the legs, trouble getting off a toilet, trouble getting upstairs, trouble getting out of a car. So we try to wean the steroid dose down as best we can. There are a lot of patients, when you wean the steroids down, the appetite goes down, they become very fatigued, and so they want to go back on the steroids. And I try to push them not to do that and just try to work through it. Use other medications like Ritalin, Adderall, or Provigil to help them become more wakeful. So if you come across that, it's a normal thing when you're coming off of steroids to have the joints ache a little bit, to feel tired, to lose weight, but you really want to get off of them. They cause a lot of problems in the long run, particularly with your ability to function. And seizure medications. Patients who haven't had seizures with brain tumors don't need seizure medications, okay? We give them to them, patients, during the week of the surgery, so a week or two, that's it, to prevent a perioperative seizure. And that's based not on brain tumor surgery data, but on head trauma data. And I will tell you, I agree with it. When Dr. Steinecke, who's going to be talking next, first joined us, we decided not to prophylax the patients with anticonvulsants because there was no data to show that it was of benefit. And out of 10 patients, we did have 40% develop a seizure in that first operative week. So we continue to prophylax everybody. Best drugs, Keppra now. Dilantin's an old drug. We don't use it anymore. Keppra, some of the newer generation. They don't interfere with chemotherapy. They don't interfere with liver function. The reason that we don't want to give patients with brain tumors seizure medication when they don't have them is because there's a 20 to 40% increase in side effects from the general population. Okay, and also for the older drugs, Dilantin, Tegretol, phenobarbital, if patients are placed on those drugs and they go and receive radiation therapy within a month and a half, they're at risk for developing what can sometimes be a very fatal rash called Stevens-Johnson syndrome. And I've seen it, and it's not pretty, where the skin literally sloughs off. And so it's very important that if you know that you've been on Dilantin or Tegretol or phenobarb for less than a month and a half and you're going to radiation therapy, that you discuss with your doctors why you're on it. So this is the multidisciplinary team that we have across the street. We have neuro-oncology, neurosurgery, the whole gamut. We have the chemotherapy nurse and clinical trial. My secretary's here. Everybody works together for the care of each patient. This is how brain tumor care should be, as Dr. Vogelbaum said, multidisciplinary. We meet once a week in our tumor board to discuss everybody's care. Mostly new cases, but we also bring up other cases that are, require further input. So we're going to talk briefly about some of the trials that are available at JFK. The ICT-107 brain tumor vaccine trials, anybody familiar with that? The company's based out of Los Angeles. It's immunocellular. Dendritic cells are immature immune cells of our body. They finished a phase 1 trial, which had very promising data, and actually the best data to date of any phase 1 trial in the last couple of decades. We opened up the phase 2 trial back in February. We were the first site in the United States. We have now 8 patients who are on the vaccine. The phase 1 trial, they took tumor tissue. They took the antigens or the proteins that the tumor had. They stimulated the patient's own immune cells in culture and attached those proteins and then gave it back to the patients to mount an immune response. So basically what they were doing was training some of the cells of the patient to sort of present the protein and say, this is what we've got to attack, and then the rest of the body would attack that protein, thus the tumor cell. At the phase 1 trial, they only were given 3 doses after surgery of the vaccine. And this is basically how it works. We take immature immune cells, put them in culture with some stimulating factors, attach the proteins that are found on the tumor, and then give it back to the person so that the cells can say, hey, attack this. And then it mounts the patient's own immune system to attack the tumor. We do not like to use phase 1 data. There were 16 patients that participated, which is a low number. We do not like to use phase 1 data to look at survival, but unfortunately we all do it because that's what we have to look at. I didn't put the slide up here because I did not want to slam other trials, but to date, when you look at phase 1 data to phase 1 data, the ICT-107 had the highest 2-year survival to date. When you do compare it to the standard of care, this is looking at progression-free survival. The progression-free survival for the standard of care is 6.9 months, okay, which means at 6.9 months, 50% of the paper had tumor progress. The progression-free survival for the addition of the vaccine, and it's given in addition to the standard of care, you get surgery, chemo, radiotherapy, and then vaccine and Timidar, was 17 months. So that's quite a large increase in progression-free survival. The median survival for the Stoop protocol, as I said earlier, on average is 14.6 months. The overall survival at 2 years is 26.5%. If you have something called MGMT, methylation, okay, MGMT is like a little carpenter guy. that comes and fixes the damage that the chemotherapy does. When that is methylated on the Stu protocol, the 2-year survival is 49%. On the ICT-107 trial, the 2-year survival is 80%. Okay. So progression-free survival at 2 years was 43% with the ICT, 10 with Stu, and the overall survival is 80 versus 26.5, or if it's methylated, 49%. Just so you understand the difference there. Again, not what we want to do comparing phase 1 data to a standard of care, but when you look at the phase 1 to other phase 1, it's a significant improvement, and we're hoping that the phase 2 trial pans that out. They just published their 3-year survival data is 55%. So they have not reached their median survival yet. Okay, so it's been more than 3 years, and they have not reached the median survival for the patients on that trial. The phase 2 trial design, it's randomized, meaning you may or may not get true vaccine. Double-blinded, I don't know, nobody knows. It's for newly diagnosed glioblastoma, age 18 or over, and the caveat is that they have to have this HLA, A1 or A2 positivity. HLA are just the type of immune cells that we have. 70% of the population, probably more now, like 80, 85%, are HLA, A1 or A2 positive. You have a 2/3 chance of receiving the true vaccine and a 1/3 chance of not receiving the true vaccine. The vaccine, as you see here, it's surgery, the standard of care. I like trials that include the standard of care because I like to know my patients are getting something that I know works. Then they get vaccine once a week for 4 weeks. Then they start monthly Timidar, and then they get the vaccine at various points. We want the patient to at least have 12 months while they're on the standard of care to get vaccine at various points. But the company says if you have vaccine left over, we can continue to give it as long as we have it. So just to summarize ICT-107, it targets the cancer stem cells and the tumor cells themselves. It has demonstrated in the phase 1 trials a significant improvement in survival at 2 years. And in addition to newly diagnosed glioblastoma, the company is interested in recurrent brain tumors, pediatric brain tumors, and ovarian cancer. Sapphire. Sapphire is a convection-enhanced delivery trial. We have it available at JFK. The main reason I wanted the trial here was because there's not a lot of trials out there for patients with grade 3 anaplastic astrocytomas. So this is for recurrent anaplastic astrocytomas, or if somebody had an anaplastic astrocytoma and it then became a GBM, they're eligible for this trial as well. It's a phase 3 study. Busy slide, not that important. Transforming growth factor beta 2 is found in the body. It helps tumors to invade, to proliferate. So the drug, what they call antisense, is basically to prevent this molecule or this protein from being formed. So the way proteins are formed in our body, we have nucleic material, or DNA becomes RNA. Everybody remember this from high school and probably college? And it makes a protein. So what they did was they created this antisense nucleic band that attaches so the protein's never formed. That's basically how it works. It's very specific. The antisense molecule comes in, binds, and prevents the formation of the protein. Oh, I didn't know I had all those little things in there. All right. This is a patient who was treated with the drug. It's directly infused into the tumor cavity. So the tumor's resected, catheter is placed. There's 7 days of infusion of the drug, 7 days of normal saline, then 7 days infusion of the drug. This is the earlier trial. We're involved in the 005 trial. So the patients are for recurrent and refractory anaplastic astros and secondary glioblastoma. There will be histological confirmation. They have to have had surgery and radiotherapy prior, and they're allowed up to 2 prior chemotherapy regimens, which is good because a lot of us go through Avastin. There's 2 groups. It's a 50% division. You either get the drug infused or you're going to get what's considered the standard treatment. At this point, reintroducing temozolomide or using CCNU. There are definitely some problems with the design of the study. They're working them out, and actually I have a meeting next week with them. They're coming out next week, and in fact, Dr. Vogelbaum and I were talking. He's meeting with them at the SNOW meeting this year, which is our big meeting that I can't be at. For the vaccine, there's going to be 11 treatment cycles, and then of course we're going to follow for progression. This is basically how it works. If anybody has a shunt, it's going to be a catheter placed in the tumor cavity, runs under the skin, around. Then there'll be a little port in the chest that you can access, and then it comes out and you wear it on your belt, and it just delivers the drug right through the port. It's called convection enhanced delivery. This is basically what it looks like. All of the stuff here to the left being outside of the body, and then everything from that port needle being under the skin. So as we heard earlier, it allows targeted drug delivery. It sort of pushes through a pressure gradient the drug into the tumor tissue, and you're able to get high concentrations. Some of the adverse effects include bleeding, infection, inflammation, and certainly some worsening of neurological deficits. Again, it's a randomized trial. They had, in the earlier studies, 2 doses, 10 and 80. They found that the 10 was just as good, less side effects. Oh, we're almost done. So also available at JFK, I think Patty, Diane, and Linda put the trials that are available across the street here. We do have the NovaCure device. It's a newly diagnosed clinical brain tumor trial for glioblastoma. We were involved in the recurrent disease trial. It was recently FDA approved for recurrent glioblastoma. We're the first site in the United States to offer it commercially. There'll be a total of 5 sites in the United States. We got certified last week, and I already have my first patient who requested it for commercial use. The other trials that we'll have here probably by the end of this year, January at the latest, is the CellDex, the brain tumor vaccine trial for newly diagnosed glioblastoma. Same concept as the ICT-107. The difference is you have to have EGFR, which is just a marker, a molecular marker on the tumor cells, positivity, and it looks at a different set of proteins. And then Tocogen. As Dr. Vogelbaum said, UCLA, Cleveland Clinic, UCSF, and we'll be the 4th site in the country for the Tocogen 511 study. I like that because I like the gene transfer therapy, and I like the fact that they allow all recurrent malignant gliomas, and not just GBMs, anaplastics, anaplastic oligos. Any recurrent malignant glioma is available for that trial. There is a size factor. That's for the phase 1. They're finishing off the phase 1. That's what we're going to get involved in, the tail end of the phase 1. But the phase 2 is going to be surgical resection and injection or stereotactic injection on the phase 2. So it may not require surgery. So that's going to be the changes that will occur in the phase 2.
And can you use an old biopsy from previous surgeries, or does it have to be current?
Well, no, you can. It's going to be the tissue pathology. So they'll probably want a central review of the path, but as long as it's a malignant glioma,
Right.
yeah.
For the NovaCure, it's accepted by the insurance companies yet?
No, that's a good point. Yeah, good point. Anybody here from the insurance companies? If you are, I hate you. It just became FDA approved. The problem is there's no code or reimbursement for it. It's an $18,000 a month treatment. It's very expensive. It's cheaper than Avastin, which is about $24,000 to $30,000 a month. That's been the problem. So the company is actively working with the insurance companies to try to get reimbursement. The particular patient that I have on it can afford it. Can afford it. But I'm not a fan of insurance companies. I'm sorry. I can't say anything nice about them. I talk to a medical director on the phone at least 3 times a week. Things that are denied, they're just absolutely ridiculous, or they'll accept it and tell the patient, well, you got to pay $5,000. I mean, it's just ridiculous. Thank you. That's the family. Mine is probably the most important one, the boss, right? My wife's not in there. All right. Anybody have any questions?
Question. My husband has astrocytoma grade 3, and he had a shunt put in. In the meantime, he had a lumbar shunt. He had one lumbar shunt, and he had 2 revisions. The surgeon died in a plane crash. Then he had, yes, and in the meantime, his new associate had given him another 3 surgeries. In the meantime, he now has a shunt in the back of his head. And look at his
So you're talking about surgeries for shunt revision?
Mm-hmm. So, I mean, what do you do? And we're trying to get a surgeon, and it seems like the big surgeons don't look like they want to touch him, but there's also like, he doesn't have cancer anymore, it's clear. So
it's more of a shunt issue.
Yeah. Absolutely.
Steve Bloomfield, I mean, I know who I know, so it's going to be hard to get that, but Steve Bloomfield is one of the brain tumor surgeons I work with across the street. He operates on all my hemispheric malignant tumors, but he also does all of the shunt work. Tom Steinecke, who you'll talk about, is my pediatric and skull-based neurosurgeon, and then I have another surgeon for spine, but he would be probably the better one. He does all of our shunt work. I mean, as a second opinion, if you want to do that.
I mean, he's been like this since the whole time, but like since like July.
I trust him enough to work with him, so.
These vaccines are testing so well, the ICT-107, the BC vax. Is there a way to get them fast-tracked? I mean, why does it take so long to get FDA approval when they're so successful? I mean, they're beating the standard of care by a large margin.
The FDA's job, I'm the chairman of the IRB here. The IRB is an institutional review board, so any clinical trial done at this institution goes through me and the committee that I am. And our job is to protect the patients. The FDA job is to protect the public. So the reason it takes so long is probably mostly because of fear. I will tell you that the company on their own is doing an interim analysis. So their median survival in their phase 1 data was 17 months. So they're doing an interim analysis at 17 months. And they're going to, if it shows a significant improvement in survival on that analysis, they're going to push it fast. They themselves want to get it out there. You have to ask the FDA why they're so slow. I'm not a fan of the government right now. I'll go right in order. Yeah.
Yeah, I just had a follow-up on that ICT-107. So they're in phase 2 now. They have about, I think they're up to about 50 patients.
Yeah, there's actually 27, 50 on the trial, 27 receiving vaccine. We have the largest number right now at 8.
Okay. So what is the FDA going to look at for fast track? In other words, I think they need about 230 altogether on the whole trial.
The FDA has fast track other things, you know, where they said, okay, stop the trial. It clearly shows a benefit for other cancers. So what they'll look for is efficacy, what the response rate is, excuse me, if it's durable. So they'll look at the percentage of people who are alive at 17 months. You know, the data already looks good for the phase 1, but you know, this is a much larger trial now. So, and when the numbers get bigger, sometimes the outcomes can get smaller with regards to how impressive they are. I don't think they're going to be that less impressive. I'm very impressed by the phase 1 trial, which is why I wanted it here. And so I'm optimistic that we're going to see significant benefits. So they're going to look at if it works and if it's safe.
But I was wondering how many patients they actually say have to be
That is statistical.
Statistically.
That's a statistical thing. I was terrible with statistics, but I will tell you what they look at is a power. They have to have a certain power to say that it's a positive study. And so the study's already designed that way. So the number of patients that they're looking for on the trial is powered to give us whether it's going to be a positive trial or a negative trial. So they just look for what's called a statistical power. And you do that when you're developing the trials early on. You look for that number of patients to get the answer that you want to get. So that's already incorporated into the trial design. The FDA is going to look at how many patients, did it work, what were the side effects. I'll tell you, the side effects so far have just been local, you know, like when you get a shot, a little red around the shot because it's injected under the axilla.
And that one they just use blood, right?
What they do is, on the original phase 1 trial, they took tumor tissue out and made the vaccine with those antigens. What they do here is we take the patient's own blood, bring it to culture. They developed all the antigens that are found in the tumors, the most important one, they develop them synthetically so that there's more even distribution because there's a lot of variability. And then, so we attach those synthetically made proteins or antigens into the patient's own blood cells that we give back through an injection.
So the
vaccine's made at University of Pittsburgh.
Right, they don't need the
University of Pennsylvania.
They don't need the tumor.
They don't need the tumor.
They do not need the tumor. And this is the only
on the phase 1 they did, on this study they did not.
Right. And then the third thing is this particular product is looking at the cancer stem cell.
In addition to the tumor cell.
Where there's no other product out there that's looking at the stem cell?
That is one unique aspect of the ICT-107. So most of the immunotherapy vaccine trials, because you've got to separate it from the vector, the retroviral, like the tocogen is a retrovirus vector vaccine. The immunotherapy vaccine trials are looking at proteins that are found on the tumor cells, which is why they use the tumor tissue of the patient. So that's not a cancer stem cell, that's the tumor cell. The same thing with Celldex. I don't know if DCVax, I think DCVax did the same thing. But what they did was they looked at antigen both on those cells that have the potential to become tumor cells, the cancer stem cells, as well as the tumor cells, and then synthetically made those proteins to include in the vaccine. That's right. Did I miss anybody? Yeah.
I'm just wondering, I'm trying to figure out what exactly I had because my father was in here, he's a physician, and he, was right on top of all of my care. 5 years ago, I got it, 3 years in remission, still 2 years of treatment. So 5 years ago, I had what I thought was what you're describing as the ICT-107. Is that possible? I was treated at Cedars-Sinai.
Yes, it's possible.
Okay. So
Cedars-Sinai is where those 16 patients were treated.
Okay. Wow.
Right? Cedars-Sinai? Yeah. I don't know if Keith, I think he might have done it, yeah.
Dr. Black is my...
Yeah, Keith, yeah, he might have done it.
Okay.
Yeah, so that's
okay,
possible.
I had the big pink thing and then, yeah.
Yeah, and they use your own tumor tissue at that point.
So what is that called then? That is the ICT-107?
That is ICT-107, yeah. That's where Cedars-Sinai is where those 16 patients were treated. Anybody else?
With the NovoCure, it seems like with NovoCure, everyone's always talking about it as a potential treatment for GBM. But it seems like what it does is disrupt cell division. Wouldn't that be useful for pretty much any brain tumor that's growing?
Yes. Yes. They are, I like the NovoCure. I think it's a novel approach. I like using it with chemotherapy. There was a subset of patients who failed Avastin on the original trial who responded to the device. So, as everybody knows, when you fail Avastin, we're not happy. Nobody's happy because we have very limited things that we can do. But yeah, it would be useful for other things. I know they're looking at it for other cancers, developing one for breast cancer that could be worn in the bra. So they have studies already in animals for lung cancer with resolution. It's a very interesting approach. It's an Israeli company. They're very nice. I meet with them frequently. They're certainly thinking outside the box.
Yeah. Question about the TTF device. My doctor says that the latest clinical trials prove that it doesn't work. Is he off base, or
no? He's just wrong.
Or is it controversial?
No, he's just wrong. No, I mean he's just wrong. He's wrong. What the actual study showed was there was no. What they did was, first of all, the newly diagnosed trial is still going on, so there's no data on that other than the European data, which, as Dr. Vogelbaum showed you, did show a benefit. For the FDA approval, the recurrent disease trial, they compared it to the best standard of care. So I said to a patient, we have this trial. This is pre-Avastin now. You have to understand this is before Avastin was around. The device, or BCNU, or CCNU, or Timidor, or whatever I want to give. Some cases it was just observation. All right, so on that trial, some cases was just observation. And what it showed was there was no difference. So if somebody got the device versus got a chemotherapy or the best standard of care, which included observation, there was no difference between the two groups. They both lived the same amount. The only difference was there were no side effects for the no-dose TPF. The quality of life was better. So it's not, so if the purpose of the study was to show it was better than the standard of care, then it didn't work. That wasn't the purpose of the study. The purpose of the study was, what is it compared to the standard of care? There was no difference. So in that way, it was a positive study because basically that's why the FDA approved it, because it was just as good as the standard of care for recurrence, the best standard of care. We're not talking about Stu now.
I just have a question. I was diagnosed with anaplastic gastrocytoma 5 years ago, and all they did was craniotomy, and I haven't had any further treatment. Have you seen that?
Is that your choice, or?
No, that's the doctor's choice.
Yeah. If the pathology...
That's his question, why?
Yeah, that's my question. No, that's not normal. I mean, I don't know if there was something about the pathology, if it's truly an anaplastic gastro, if it was an anaplastic. There should have been other treatment, in my opinion. Anybody else?
Is it possible to get the copies of the slides that are presented here today?
Yeah, just ask Patty, my little nurse. Got a lot of patients here, too. Yeah, we do. I mean, I'm not really, I don't know the insurances. I know you.
Survival is from what? Date of diagnosis?
Date of diagnosis. So all the survival data is the date of diagnosis. Yeah. So somebody could have had a low-grade tumor for 5 years before it was diagnosed. Survival still based on diagnosis.
What's the status of solandertide?
The solangenitide trial just closed. Solangenitide is an integrin inhibitor, just another molecule that we're looking to inhibit. The trial just closed earlier this year. The preliminary trial showed that it was active, but I don't even know if they're going to have the preliminary data available for the meeting in November. Even though I'm not going to be there, I'll get the summary. But it's just another molecular marker like Avastin and like others are. Cediranib. Does anybody know cediranib? Avastin is a vascular endothelial growth factor inhibitor. Cediranib was a vascular endothelial growth factor receptor inhibitor. The trials basically showed it had a modest effect, so it wasn't a great trial. But the solangenitide is closed, and they're analyzing the data. I know you too.
I know you know the person, I don't want to mention the name, but she had moved and her oligo came back.
Yeah.
And you wanted to put her back on the Tumor.
I did.
And then 1 month she had to pay, and then you finally got like 6 months approved for the insurance. What happens if you get on that, and then after 6 months the insurance gives you a problem? Have you seen that happen?
The answer is some insurance companies don't care. I mean, I don't know what to say. They don't care. I have a patient who I put on Tarceva. She was a 44-year-old mother of 2. She's since passed away. And the insurance company was very reasonable. I told them my rationale. The medical director said, I'll give it to you for a month. If she responds, you could stay on it. She responded for 18 months. So they paid for 18 months. That's a good insurance company. All right. Thanks, everybody.
Thank you. That was wonderful.